So we looked at symptoms of cystitis and pyelonephritis. We analyzed the results of urinalysis. We ensured urine cultures are taken in patients with pyelonephritis and recurrent cystitis. We also recommended effective drug therapy for treatment of cystitis and pyelonephritis. Now, the next learning objective is change empiric therapy to pathogen-directed therapy based on urine cultures and susceptibility results. The concept of collateral damage refers to unintended ecological adverse effects of antibiotic therapies, and this includes selection of drug-resistant organisms as well as unwanted development of colonization or even infection with multi-drug resistant organisms. Here's how selective pressure works. The normal flora includes a diverse population of bacteria, and this diversity is beneficial for health because these organisms can actually compete with pathogenic bacteria for growth. So they actually prohibit the growth of pathogens. Although these bacteria are beneficial for health, some of them could actually include genes for resistance. So imagine these two strains of bacteria that are pink, they actually include genes for resistance. Although they are resistant to antibiotics, they are not really causing any infection or any problems in the host. Now imagine that you start using antibiotics for an infection. While the antibiotic is important for killing the infection, the antibiotic can also kill all these beneficial flora. And when it happens, all the flora that are susceptible to the antibiotic will die, except those beneficial bacteria that were resistant. And because those resistant bacteria, although they are not causing any problem, because they stay around, they actually become the dominant species as part of the flora. And now, the majority of the flora include genes for resistance. And then when the day comes when an actual pathogen invades the host and causes infection, these flora can actually transfer those resistant genes to the pathogenic bacteria from plasmids and cause infections that are resistant to antibiotic. And this is referred to as selective pressure, where the resistant organism becomes the dominant species. This selective pressure is greatest with broadest antibiotics, and the risk is lowest with narrowest antibiotics. So therefore, it is important to keep that in mind, and when we select antimicrobial agents for our patients, to choose the narrowest possible option. This pyramid is designed to help you understand broad versus narrow spectrum of activity. It is important to know that there is no such thing as a tiering system when it comes to broad versus narrow spectrum of activity. I have created this pyramid just to help you understand broad versus narrow. Now, the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are, the more broad the spectrum of activity. And broad versus narrow is not really a head count of how many organisms are covered by a specific antibiotic, but rather it is the propensity of causing collateral damage. So tier 1, which is considered pretty narrow, is essentially the urinary antibiotics, so nitrofurantoin and oral phosphomycin, as well as penicillin. So penicillin is considered the narrowest antibiotic when it comes to beta-lactams, and nitrofurantoin doesn't really go anywhere in the body other than the urine, so these agents are unlikely to cause collateral damage in the body. Slightly higher, so these are, tier 2 is still pretty narrow, but relative to tier 1, slightly broader, and these are first generation cephalosporins such as cefazolin, and also ampicillin and trimsulfa. So tier 2 is also pretty narrow, and these are good agents to de-escalate when we are using broad spectrum antibiotics. Now, I'm not going to be able to fit everything in there. So for example, I'm skipping second generation cephalosporin, so you can think of second generation between tier 2 and tier 3. And tier 3 includes third generation cephalosporin such as ceftriaxone, as well as ampicillin sulbactam and amoxicillin clavulinate. Now, these agents up to tier 3 do not have activity against ESBL producing agents. But, when you get to the third tier, it's actually pretty broad spectrum. Now, tier 4, slightly more broad than tier 3. What's unique here is that ertapenem and gentamicin, they do have activity against ESBL producing agents. ertapenem is a carbapenem that does not have activity against Pseudomonas, and gentamicin is an aminoglycoside that recently it is decided that it no longer has activity against Pseudomonas. So for that reason, because they don't have activity against Pseudomonas, they are placed in tier 4. Now from tier 5, this is where we get Pseudomonal activity. So everything in tier 5 has activity against Pseudomonas. And this is considered pretty broad. So unless you are trying to cover for Pseudomonas, you shouldn't really be using these agents if you have options. So cefepime, which is a 4th generation cephalosporin, ceftazidime, which is a 3rd generation cephalosporin, piperacillin tazobactam, fluoroquinolones such as ciprofloxacin, levofloxacin, and also the aminoglycoside tobramycin is pretty active against Pseudomonas, and amikacin is considered active against Pseudomonas in the urine only. Aztreonam is also a beta-lactam that's active against Pseudomonas. And tier 6 is actually more broad than tier 5. So these are pretty much carbapenems as well as ceftolozane tazobactam. These are not only active against Pseudomonas, but also active against multi-drug resistant Pseudomonas. So if you have Pseudomonas that's resistant against tier 5, tier 6 will still remain an option. So for that reason, they're considered more broad. And in the same sense, tier 7 is more broad than tier 6, because if you have pathogens that are resistant to tier 5 and 6, tier 7 may still be active. So you really want to reserve these. And in most hospitals, tier 7 and as well as sometimes some agents from tier 6, such as ceftolozane tazobactam, they're typically restricted. So you would need approval from the ID team to be able to use these agents, not only because you want to reserve them for resistant pathogen, but also these are pretty expensive. Another thing to keep in mind when selecting agents for treating urinary tract infection is penetration to the site of infection. Nitrofurantoin and oral phosphomycin are excellent for cystitis. However, neither of them stay in the renal tissue, so they go straight into the bladder. They don't. So they go completely into the bladder. They don't stay in the renal tissue. So therefore, nitrofurantoin and phosphomycin, specifically oral phosphomycin, should not be used for pyelonephritis. Moxifloxacin also does not go into the bladder, so moxifloxacin should not be used for cystitis. In this table, I'm showing you the percentage of different antibiotics that actually get excreted renally, as well as some antifungals. What I want you to know from this table are the bolded agents, and not necessarily the percentage, but the fact that these bolded agents get enough concentration in the urine. Now here are the recommendations from the 2023 IDSA guidance on the treatment of antimicrobial resistant gram-negative infections. Specifically, we will focus on ESBL producing Enterobacterales causing UTIs. So when it comes to uncomplicated cystitis, for ESBL UTIs, the preferred agents are still nitrofurantoin and trimsulfate, assuming that the ESBL producing organism is susceptible to nitrofurantoin and trimsulfate on urine culture. So you do need to have urine cultures, first of all, to confirm that this is ESBL, but also if it happens to be susceptible to nitrofurantoin and trimsulfate, then these are the treatments of choice. Now, it is common for ESBLs to be resistant to also nitrofurantoin and trimsulfate, but you just wouldn't know until you have the results of the urine culture. Now, if it happens to be resistant to these agents, then you have alternative agents. So for cystitis specifically, you can use just a single dose of aminoglycosides, assuming that these are susceptible on the urine culture. So, anything that's resistant on urine culture, you just eliminate from this list. Oral phosphomycin would be an alternative option for E. coli only. Of course, fluoroquinolones as well as carbapenems. And you do want to avoid these agents because they are not effective for cystitis. So doxycycline and amoxicillin clavulanate, as well as cefepime. So these are proven to be have inferior efficacy, When it comes to cefamycins such as cefoxitin and cefotetan, there is insufficient evidence out there, so we just don't know if they will be effective. So until more evidence is available, they should be avoided. Now, for pyelonephritis and complicated UTIs, the preferred agents, again, assuming that these are susceptible on urine culture results, is trimsulfa, fluoroquinolone, and erdopenem or meropenem or imipenem. For, if the culture is also resistant to this, then alternatively, once daily aminoglycosides. Now, this will be the full course, not just a single dose. And of course, again, you want to avoid, because this is pyelonephritis, you want to avoid nitrofurantoin and oral phosphomycin, as well as doxycycline. And because this is ESBL, cefepime has inferior efficacy. And for cefamycins, there is insufficient evidence at this point. Majority of cases of uncomplicated UTIs include cystitis, so nitrofurantoin, 5 days of treatment is adequate. With phosphomycin, total duration of therapy is just a single dose. Now, these are in most cases. For example, if someone has ESBL UTI, a single dose of phosphomycin may not be adequate. For pyelonephritis with IV beta-lactams, total duration is 7 days. The same is true with fluoroquinolones, whether it's IV or PO. And that would be 7 days total. So let's say if someone got IV beta-lactam for the first 3 days, and then they were switched to a fluoroquinolone, then they just do 4 more days of fluoroquinolones with plus the 3 days of IV beta-lactam to give you a total 7 days. With Bactrim, 14 days is required, as well as PO beta-lactams. So because PO beta-lactams are inferior to IV beta-lactams, you need 14 days of treatment, and PO beta-lactams are last option. Let's say if someone got 3 days of IV beta-lactam, then they get 11 days of trimsulfa to complete 14 days of treatment. With complicated pyelonephritis, we do not have clinical practice guidelines. So in general, most clinicians agree on 7 to 14 days of treatment. However, there is clinical evidence that 7 days of treatment is sufficient for most patients with complicated pyelonephritis. So I would recommend 7 days of treatment for complicated pyelonephritis. So let's take a look at the case study. So let's say CR is a 50-year-old woman with no significant past medical history and no known drug allergies, who is being treated empirically for pyelonephritis with ceftriaxone 1 gram IV every 24 hours. So let's say today is day 4 of treatment, and she's clinically well. Here's the results of the urine culture. So the organism is E. coli, and the susceptibility results have come back. So basically, R means resistant. So amoxicillin clavulanic acid is resistant. Ampicillin sulbactam is resistant. Cefpodoxime is susceptible. Ceftriaxone is susceptible. Ciprofloxacin is resistant, and trimsulfa is susceptible. So what would you use? So far it's been ceftriaxone. Ceftriaxone is IV, and at some point, if the patient is ready to go home, we can change this to PO. So ceftriaxone only is available as IV. So but first of all, you want something that's susceptible. You don't want to use something that's resistant. So augmentin, for example, is PO, but because it's resistant, we're not going to be able to use it. So from the things that are susceptible, trimsulfa is available PO. And so is cefpodoxime. Cefpodoxime is a 3rd generation cephalosporin that's available as PO. So you have 2 options left. So between the two, the correct answer would be Bactrim, because PO beta-lactams don't get enough concentration in the urine. So if you do have options, PO beta-lactams should be your last option. So for example, if this patient happened to have sulfa allergy, then trimsulfa would not be an option, and then you can use cefpodoxime. But since this patient does not have sulfa allergy, we would go ahead and choose Bactrim, or trimsulfa would be the best option.